So I'd like to welcome everyone to the first Faculty Academic Staff Forum of the spring semester here at UW Eau Claire. My name is Erica Benson. I'm the Director of the Office of Research and Sponsored Programs, and I have the honor of introducing today's speaker. Dr. Vidhu Anand is an Assistant Professor of Medicine and Senior Associate Consultant in the Department of Cardiology with joint appointment in Rochester. She completed medical school in India, residency at the University of Minnesota, fellowship and advanced fellowship in imaging at Mayo Clinic Rochester, after which she joined as consultant in Rochester and transitioned to practice in Eau Claire a year and a half ago. Dr. Anand has extensive research experience in valvular heart disease, pulmonary hypertension, and cardiac imaging, has authored 50 research papers and received research awards. Dr. Anand is also a member of the local American College of Cardiology and national committees, and she is passionate about education and has been actively involved in teaching and mentoring students in research. So Dr. Anand started pulmonary hypertension practice a year and a half ago in Mayo Clinic Health Systems in Northwest Wisconsin, and we are delighted to have her as our first speaker of the semester today. And how appropriate it is that this is Valentine's Day, and we have a talk about the heart. The title of her presentation is "What is the appropriate timing for surgery in aortic regurgitation?" And before I turn the stage over to Dr. Anand, I want to first thank our partners in hosting the Faculty Staff Forum, and that is the Center of Excellence for Teaching and Learning and Technology Services, who have helped us get set up, get our technology ready, and also make it possible for us to Zoom the talks and record them. And for our remote viewers, hi everyone. We encourage you to submit questions using the Q&A function at the top or bottom of your screen, and our graduate assistant, Matt, will read those aloud. And then I do ask you, Dr. Anand, if we have any questions from the audience, if you could please repeat them for the benefit of the online viewers, since your microphone is key here for them. So please join me in warmly welcoming Dr. Anand.
Well, thank you so much for this wonderful opportunity and very kind introduction. So today we're going to be talking about aortic regurgitation and the timing of surgery. I don't have any relevant disclosures. I do some consulting for Tori Echo Committee that reviews echoes for pulmonary hypertension drug trials, and I'm funded through Mayo Clinic Rochester intramural grant. My learning objectives are to briefly review the different methods for assessing the valve, severity, etiology, and mechanisms of aortic regurgitation or leaky aortic valve, to review the current surgical guidelines for aortic regurgitation, and to discuss the novel markers used to evaluate left ventricular remodeling in aortic regurgitation. I heard that my audience may be quite diverse, so for those who don't have a background in biology, as we know, there are 4 valves in the heart. The aortic valve is the valve that's between the main pumping chamber, left ventricle, and the big blood vessel aorta that carries blood to the whole body. And here in this animation, you'll see this is the valve, aortic valve, that is leaking. It doesn't close appropriately and diastole when it's supposed to. And as a result, that extra blood comes back to the left ventricle or the main pumping chamber, causing it to dilate over time. All right, so we're going to look at what causes aortic regurgitation, the etiology and mechanism. As a cardiologist, whenever we are seeing patient, come in with a condition, particularly with valve condition, as my learning objective stated, we try to evaluate a number of different things. The valve severity assessment is important because mild or moderate and even severe many times doesn't cause symptoms and we don't really need to fix it. The second, what is causing it? What's the mechanism? Because that helps us in planning the appropriate treatment. And then to really determine when to intervene, when to perform the surgery or refer the patient for surgery depends on, of course, if they have symptoms or not, and the impact of the leaky aortic valve on the left ventricle. All right, so the first part is etiology and mechanism, and I'm going to start with a case. A patient I saw is an 82-year-old male, real patient example, comes in with shortness of breath on activity for 6 months. His past medical history is significant for hypertension and kidney disease. And on physical examination, he had a loud murmur noted in the aortic area. He had another murmur at the LV apex, so he had 2 leaky valves. The other one probably was mitral regurgitation based on the position or location of the murmur. And the first test that we usually do after, of course, labs and ECG is the ultrasound of heart or echocardiogram. And these are his images. And this echocardiogram shows that the valve is leaking, this blood kind of coming back here in this phase. This is the short axis view of the valve, which has 3 cusps. You can see, the valve is thickened, the increased whiteness. The valve that's not thick would not be this, echo bright. This is thickened. There's almost a, nodule here, degenerative nodule. And then again, leak. It appears severe. This is another view showing this blood kind of coming back to the ventricle, left ventricle. So now the question is, it appears severe, but what's the etiology and mechanism? Based on these images, actually, I couldn't tell. And so typically what happens, the next step is TEE or ultrasound of the heart by putting the probe from the mouth into the food pipe, because by doing that, we come real close to the heart. The esophagus or food pipe is right next to the heart, particularly the aortic valve, so we could take a detailed look. Now, in this case, we knew it was severe. Yes, the etiology and mechanism wasn't clear, but patient was sent for surgery right away because we didn't want to delay surgery. And during surgery, we do perform echocardiogram, the TEE, the transesophageal. And when I put the probe down, these were the first couple of pictures that I obtained. This was a patient at operating room at Mayo Clinic in Rochester. So right away I saw, oops, there is something very abnormal in this area between the aortic and the mitral valve. It looks like a pseudoaneurysm. And this valve is actually perforated. It has holes in it where the blood is leaking from. And on short axis view, again, I saw that pseudoaneurysm and the perforation. So that suggests actually infective endocarditis or infection of the heart valve. Now, this isn't an active infection because patient did not present with fever, chills, he didn't have bacteria in his blood culture. But upon reviewing his chart, this was a case I was mainly involved in the OR, so I didn't know about the history leading up to the operation. But then when I dug in his chart, we found this patient was referred from outside, a different state, and he actually had 6 months ago an infection that was kind of some respiratory symptoms, was treated with a very brief course of antibiotics, which we know is inadequate for treating endocarditis, where patient needs 6 weeks of antibiotics. So now in this case, knowing we knew it was severe, the valve needed to be fixed. So how did, knowing the etiology and mechanism helped? It helped because it changed the surgical plan, and I'm going to come to that in a sec. So the mechanism is type 1. There are 3 different types based on the leaflet motion. And type 1 means the leaflet cusp motion is normal, but there is something either anatomically wrong with the cusp, such as a perforation, or there could be something wrong with the aorta, which means if the aorta is too dilated, the cusp may be normal, but they just don't coapt because the annulus is just dilated. That's also type 1, and the etiology was endocarditis. Now, how did it help with the surgical planning? Because that pseudoaneurysm was in this area, so now the surgeon not only replaced the valve, but also replaced the root, or this part of the aorta, which is right next to the valve, which if we didn't know, would be left alone, and patient would have suboptimal results. And post-operative results were excellent. Patient is doing great. He's about 3-4 years out of valve surgery, still has no symptoms, and leading a pretty active lifestyle. So there are, as I mentioned, there are 3 different mechanisms. Type 1 is when the leaflet or cusp motion is normal. And it may be because of the perforation, or it may happen if there is dilatation of the aortic root or the aorta, because it's right next to the valve, because if it's dilated, the valve just doesn't coapt. Now, type 2 is the excessive cusp motion. So one of the valve cusps has excessive motion, and instead of coapting normally, it would just prolapse as a result, creating a hole or incomplete coaptation. And type 3 is restricted cusp motion, which happens in inflammatory valve disease. We see that sometimes in patients with lupus, rheumatoid arthritis, some other autoimmune condition where valve leaflets get inflamed, and as a result, they get thickened and restricted, and they just don't coapt well. And I'm going to show an example of that in a bit. Now, etiology, as I mentioned, some of the things, typically we categorize it into etiology either related to the cusp itself or the aorta. And some of the cusp abnormalities include infection, rheumatic fever, some congenital heart condition where instead of 3 cusps, patients are born with 1, 2, or 4 cusps. Inflammatory valve disease and degenerative valve disease, and any abnormalities of the adjacent aorta, where if there is dilatation, as we see in Marfan's, sometimes long-standing hypertension. And then there are similar reasons and some reasons that are different for acute aortic regurgitation as well. So now, one thing I always tell, and it's maybe a little bit not so relevant for you guys, but for us, whenever I teach the trainees, the cardiology fellows, I say, it's very important to keep in mind that etiology and mechanism does not mean the same thing. And there are numerous examples of that, but this is one example. So if there is dissection of the aorta where it's an acute, life-threatening, emergent condition that needs to be typically fixed, pretty quickly, otherwise has high mortality, where the wall of the aorta, the big blood vessel, gets split. So the endothelium, the internal layer, gets split from the rest of the vessel wall. And so if there is dissection, the etiology is dissection, but mechanism could be 1, 2, or 3. And it could be 1 if there is associated aorta dilatation when the valve cusps are totally normal. It could be 2 where there is associated bicuspid aortic valve and one of the cusps just prolapses. So instead of meeting in the annulus here, it's just kind of prolapsing down into the left ventricle outflow tract. Or it could be mechanism 3, where the dissection flap is actually prolapsing through the valve, impairing the coaptation of the valve cusps. So whenever we perform the echocardiogram, particularly those of us who are imagers and really dedicated to imaging of valve disease, we really make sure that during our imaging, we are answering all of these questions. We are looking at the severity of valve leak, and we're also looking at, the mechanism and a lot of the times etiology as well. So the next thing, we'll move on to the severity assessment, and we're going to do that with another case example. This is 35-year-old male. He has tricuspid aortic valve, so normal. He has progressive aortic regurgitation, which has been increasing over time. And he comes in, he says, now he's just not as active. He just feels a little winded, a little fatigued. And on physical examination, again, he had a very loud murmur suggesting severe aortic regurgitation. So now we performed, again, the first step after labs and ECG is typically ultrasound of the heart. And when we performed the ultrasound, this is what we found. So his left ventricle chamber is already starting to dilate quite a bit because of all that extra blood coming back to the left ventricle in diastole. Now, here is that example of thickened valve leaflets at the cusp, the type 3 mechanism. It's thickened and restricted that it's impairing the coaptation. And instead of closing, there's almost, you could see the hole, the incomplete coaptation of the valve cusps. Also can see it in the short axis view and a big jet of aortic regurgitation. And this is another view showing a lot of blood coming back to the ventricle in diastole, the leaky aortic valve. Now, what is very interesting is during severity assessment, there are a number of markers that help us determine the severity. I mean, with aortic valve, particularly leaky aortic valve, if we look visually, it could be very misleading because, a lot of the times people used to believe you just look at, how big the jet looks and you say, okay, this is big enough jet. It's covering like more than 65% of the left ventricular outflow tract where it's leaking from. That looks severe. But we have many research papers and our clinical experience of many patients showing that we are wrong when we don't quantify the aortic regurgitation. So at Mayo Clinic and many other places, people, the echocardiographers really try to quantify the degree of aortic regurgitation, which is the standard we should really strive to achieve for every single patient. Because especially if the jet is eccentric, which we see a lot of the times with aortic regurgitation, visually, it may appear mild, moderate, but it could be severe. So we could miss a severe valve disease just relying on our eyes and saying, oh, the jet looks big or the jet looks small. So how do we quantify? There are actually a number of different ways, and I'm not going to go into the technical aspects of that, but there are some measures that are qualitative, such as, visually looking at the jet and what circumference or what area or what diameter of the left ventricular outflow tract where it leaks from it occupies. Then there are some other measures. If there is, a leak, then we see diastolic reversals in abdominal aorta. So when we do ultrasound of the heart, we actually scan all the way down to the aorta. And so that's another semi-quantitative method. And then there is some physics and echo math that actually help us calculate the exact leak of the aortic valve in milliliters. So for this example, this is a method, a PISA method. If there are any physics major in the audience, they might know. But what happens is the velocity of the red cells increases as it approaches a hole, right? And so we set up a velocity, a Nyquist limit, at which the color would change from red to blue. By setting that color, it helps us find a shell where there would be velocity change, right? And in this case, this border. And then measuring from the valve closure to this will provide a radius. And in putting it in a math equation, which I remember by heart, but I won't bore you with, we can calculate the regurgitant volume as well as the regurgitant orifice area. And then we have some thresholds that tell us if it's mild, moderate, or severe. And for aortic valve, anything over 60 ml of blood leaking with every heartbeat and an orifice area of more than 0.3 centimeter square is severe. So this is kind of the pretty complex looking guideline document that have some of these thresholds that I just mentioned. But basically, the bottom line is that we use a few different things. So this one is called vena contracta, where we look at the narrowest part or neck of the flow convergence, the flow that's coming back, and a value over 6 millimeter is considered severe. So the bottom line is we try to really quantify, and there are a number of different ways to quantify. And if we can't, we put together at least a couple of qualitative and semi-quantitative measures to assess the severity. And sometimes we just can't. And in those cases where the jet is very eccentric, our patient's imaging is difficult because either patient has COPD, scoliosis, or they are big and have large BMI, and we just cannot get good diagnostic images. In that case, we either do the TEE, the transesophageal echocardiogram, or cardiac MRI, which has a growing role in assessment of valve disease, which we'll talk about as well. Now, simple measures, like vital signs, blood pressure and heart rate are actually also very important in assessment of aortic regurgitation. And in our echo lab, mainly in Rochester and most of the times here at Eau Claire too, we get the blood pressure when the patient is coming for echocardiogram. And this study by my colleagues at Mayo Clinic in Rochester found that a blood pressure less than the lower blood pressure, the diastolic, less than 70 was associated with higher mortality. And when it reached 55, lower than 55, the hazard ratio for mortality was quite high, reaching 2.14. Similarly, the resting heart rate was associated with poor prognosis, and a heart rate over 60 was associated with higher all-cause mortality. Now, I mentioned cardiac MRI. So what role does cardiac MRI have in assessment of aortic regurgitation? We're going to do that again through another case example. A 75-year-old male with ascending aortic aneurysm, so dilated aorta, comes for follow-up. He's under surveillance for 9 years. His aorta is dilated, but hasn't reached the threshold for intervention or surgery yet. His AR, the aortic regurgitation, has been over time getting increased in severity, was mild in the beginning, and it's been progressive, and now it appeared moderate. He's been asymptomatic, quite active for his age, but he did have a loud murmur on exam. Now, the echo was done and showed, okay, the regurgitation looks moderate. There is no change in the LV size, the left ventricle size, and the ejection fraction is normal. So when the MRI was actually performed to look at his ascending aorta, but we said, okay, we are getting MRI anyways, why not look at the valve too? Because there was a little bit doubt that the murmur is now appearing louder than it was, but the severity by echo still is less than severe. So we wanted to confirm that as well. So we said, we're getting MRI for assessment of the aorta, why not get additional information about the valve as well? So the aorta was dilated and has now reached 55 millimeters or 5.5 centimeters. And this is the leaky valve, you can see. And we can also calculate the leak in MRI by 3 different methods. The first method is, if there is no other valve leaking, then we look at the amount of stroke volume, the blood pumped by the left heart and the right heart, the left ventricle and right ventricle, and just subtract the 2, right? The left is going to be higher because of all that extra volume that's coming from leaky aortic valve, right? We subtracted, we got 30 mL, and regurgitant fraction, 30 by 92 was around 33%, which again is moderate. And then we went on, the other method is called 2D phase contrast. I think I have a image of that coming up, where we take a slice, imaging plane through the aorta, and we just look at the flow, and we could see the flow in systole and the flow in diastole. And we can again, actually in volumes, get the regurgitant volume and regurgitant fraction. And regurgitant fraction is what amount of the total blood is coming back. And a value more than 50% is considered severe. So in this case, we used another method, which is 4D flow analysis, which actually gives us flow vortices in a 3-dimensional space and over time. So that is 4D flow analysis. It is really state-of-the-art new technology, but fortunately, we have it both at Mayo Clinic Rochester and Mayo Clinic Eau Claire. We're very fortunate to have it. You can see exactly how the blood is flowing through in different chambers of the heart and in aorta. And here, if you look at this blood leaking back in the ventricle, and we can put a sample volume, and we calculate it through that regurgitant flow and fraction, again, very similar to the numbers we got by volumetric analysis and concordant with moderate aortic regurgitation. So role of cardiac MRI in assessment of aortic regurgitation is, there are 3 important roles. Number 1, it can help assess the severity when echocardiography is challenging or inconclusive or non-diagnostic. It can also help us assess concomitant aortic disease, because a lot of the times patients would have ascending aortic dilatation or aneurysm. So we can get information about that and the valve. And number 3, we can also assess the impact of leaky aortic valve on the left ventricle. Which brings me to the final part of the presentation, which is going to be the predominant part, and where most of my research is focused there on, and I'm really passionate about it, is LV remodeling in aortic regurgitation. And we're going to do that with this case example, that actually a patient example that motivated me to pursue research in this field back in 2019 when I was a fellow. That was the first time when I started looking at aortic regurgitation and LV remodeling. So this is a 44-year-old asymptomatic male from Chicago area with bicuspid aortic valve. He came for second opinion. He had an excellent cardiologist back home, but was following up with us at Rochester for second opinion. So he was referred for aneurysm repair and valve replacement. His mid-ascending aorta has now grown to 5.7 centimeter, and the cutoff for surgery is 5.5. And 3 years ago, it was much smaller, 4.8. So not only it has now reached the threshold, but it has also grown significantly over a span of 3 years. So he met kind of two criteria for surgery. His past medical history, he had endocarditis in 2006, and he has severely leaky valve for 3 years prior to presentation, which brings me to another important point, which we're going to talk about a little bit later, that the leaky valve, the leak, even if it's severe, we don't need to operate. It can be well tolerated for years, sometimes decades, before it starts to cause problems. On physical examination, he had a very loud murmur, and his heart had enlarged because his left ventricular apex impulse had displaced as well. And on basic tests like ECG, 3 years apart, we could see significant changes. You'll notice that the voltages here have increased, suggesting left ventricular hypertrophy, that over time his heart has enlarged. And on chest X-ray, between 2015 and 2019, there was now this big bulge showing the dilated ascending aorta, which appeared way more prominent than 4 years ago. And now, he went for aortic valve surgery because it's severe. If we are fixing aorta, we are going to fix everything at the same time. But even at that time, he wasn't really symptomatic from leaky aortic valve, so he didn't quite meet the criteria for surgery. And so one of the criteria for surgery is symptoms. The second criteria for surgery is if there is impact on the left ventricular pumping function and the ejection fraction drops to 55% when normal being 65%. And or if the left ventricle enlarges beyond certain thresholds, and those thresholds are 50 millimeter mercury for end systolic and class 2B criteria, which is kind of a lower level of evidence, is 65 millimeter for end diastolic, but it has to be present on like 3 or more studies. So it's a lower level of evidence. And so when I looked at this patient's echo, outside hospital images, this one was at Mayo Rochester, 4 years apart. His end diastolic dimension had only changed 3 millimeter. End systolic changed 2 millimeters, still was below the 50 millimeter cutoff for surgery. But when we looked at the volumes, they had significantly enlarged from 248 cc's for end diastolic volume to 320 cc's, and end systolic volume is at the end of systole from 134 cc's to 190 cc's. So this was like a moment for me that the linear dimensions that we are using in our guidelines are not capturing how the left ventricle enlarges in these patients. And it's more like an analogy of, soccer versus football, if you will, that it's not going to enlarge spherically. It may enlarge from base to apex. And if you're looking at one dimension, it's not going to capture how the whole left ventricle remodels. And we may miss the appropriate timing for surgery by using the dimension because they may appear similar or unchanged over time, when in fact, their left ventricle is undergoing a significant dilatation over that span. And this patient, I look back at that because when he had the valve surgery, was successful, he was discharged, his pumping function was 45%, when normal is 60-65%. And at 6-month follow-up, again, it was similar, 40-45%. At 1 year, it was still 45%. So it never recovered back to normal. So we followed the guidelines, right? We intervened when the guidelines recommended per the evidence, per the American Heart Association, American College of Cardiology guidelines. Then why did our patient have suboptimal result afterwards? And this is a 44-year-old male. This is a young male who had 3 or 4 decades of life left, right? So that made me investigate this question of how do left ventricular volumes capture the remodeling. And before that, just a brief recap of the guidelines. So in leaky aortic valve, we operate if they have symptoms, which is class 1 indication, highest level of evidence. If they're asymptomatic, we look at a number of things. If their pumping function drops, normal being 60-65%. So if it's less than 55, or if they're undergoing other cardiac surgery, like our patient, in fact, then we fix the valve. If their EF is preserved, the ejection fraction or pumping function, then we looked at the dilatation more than 50 millimeter or index more than 25. Or if they have progressive increase in LV size or progressive drop in EF, even if it doesn't reach the threshold, but it's a much weaker level of evidence to be. And if they're moderate and they're undergoing any other cardiac surgery, we try to fix that other valve as well. So I look back, okay, the guidelines are recommending these numbers, but where are these numbers coming from? And it's very interesting. It was also kind of an eye-opening moment that these guidelines are actually based on research done in 1970s to 1990s, maybe early 2000s, when we had, crude ways to assess LV size. The technology has advanced significantly in the last few decades. At that time, we had M-mode echocardiography, where we didn't even know where we are measuring from. You're putting like a blind spot and just assuming that what you're getting is the biggest dimension. And in that surgery, it was a very well done study, but look at the patient numbers, less than 50 patients. So we are operating on thousands and thousands of patients based on guidelines involving, based on studies that included 50 patients from 1980s using, archaic data. And in this study, again, it was well done study by Dr. Bono and his group. He was at NIH at the time, where they followed the patients, and they found that when the asymptomatic patients are followed up, when they reach this, cutoff of 50 millimeter, that's when most of them either start to develop symptoms or need valve surgery. And when they did some other analysis, they again found the end systolic dimension to be associated with onset of symptoms and death. This is another study by Dr. Bono and colleagues in 1991. Still, about less than 100 patients, where they looked at 50 some. And when these asymptomatic patients were followed over time, there was a significant increase in likelihood of death symptoms or left ventricle pumping function dropping when the end systolic dimension was over 50. And there was sudden increase from 6% to 19%. And at that time, operative mortality and complication rate was around 10 to 20%. So that's when, weighing the risk and benefit, they decided that 50 millimeter is the cutoff that should be used, because at that time, the risk of surgery would still be less than the risk of dying from untreated valve disease. But in last few decades, there has been significant advancement in surgical technique. Now our mortality is 1 to 2%, especially for young, healthy patients, from 10 to 20%. The valves are newer generation. The valve prosthesis have less complication rate overall. And the way we assess LV size, the left ventricle size, has changed significantly. Now the guidelines recommend assessing the volumes, measuring the volumes as the way to assess the LV size. So it is really time to relook at those patients and how their LV remodels over time, taking into account the new technique of LV volumes and the updated, recent evidence in setting of very low surgical complication rate and mortality. So on that line, my colleagues at Mayo Clinic, Dr. Pelika, my mentor, this first study, it wasn't looking at volumes, but they looked at dimensions, and what they found that 50 millimeter in a 6'1" male who weighs 300 pounds, his heart size, we're using the same number for that, and a 5 feet or 4'11" petite female. How can you expect the two hearts to be similar between a male, difference in sexes, difference in height, difference in body size, and using the same number? So what they found that indexing, using that number 25 millimeter per meter square is actually a better way of capturing the LV size than using an absolute number. Because by the time a petite female's heart enlarges to 50 millimeter, it's probably too late, right? But if we index, that's a better way to capture it. And indexing actually showed to be better association, to have better association with outcomes and all-cause mortality. And they found that in fact, 25, by the time they reach 25, there is a significant increase in mortality. And it actually starts to increase at a much lower threshold of 20 millimeter per meter square. So this was their study a few years back. And then this was a very small study, again, done at Mayo Clinic Rochester. The goal of the study was to look at why quantification is important rather than visual estimation. But on the side, they also looked at LV volumes. And again, this is just one figure from that paper, 2008. Again, the goal was mainly to look at quantification, so they did not specifically look at volumes, but they found that end-systolic volume more than 45 was associated with increased cardiac events. And so before I show you my research, I am just showing an example of how we do the LV volumes. It's actually pretty easy to do. We have these views, a 4-chamber view of the heart, a 2-chamber. We trace these volumes. This is the 2-dimensional method, biplane method of disc summation, which we use most of the times. At Rochester, we pretty much all the time when images are adequate, try to do 3D volumes. So this is just an example showing 3D left ventricular volume assessment and ejection fraction, and this is how we get the numbers. Advantages of 3D is there's no foreshortening, no geometric assumption, because in this we assume the ventricle to be prolate ellipsoid, and it's more accurate and reproducible, the 3D. So 3D should be done whenever we can, but even 2D is feasible most of the time. So then, based on that patient example and a few other patients that I had seen and the limitations and guideline, I went ahead and developed a cohort of patients with pure aortic regurgitation, if they, making sure they did not have any other valve disease, did not have any other reason to have LV remodeling, either hypertrophic or infiltrative cardiomyopathy or any other kind of cardiomyopathy that could affect LV remodeling. And we included 1,100 of patients who were pure AR. And what we found, and I traced volumes on most of those patients, it took about a year of many weekends and nights on my own time while doing the clinical fellowship to trace these volumes retrospectively. We found that, there were 30% of patients who had enlarged volume beyond that threshold. And we found a similar threshold in our spline curve analysis when we plotted the volumes against all-cause mortality. So 30% patients had enlarged volumes when their LV size by just the linear dimension was less than the threshold for surgery. So that's a third of the patient in whom we may be missing the LV enlargement by following the guidelines. And, one of the criticisms was when we talk about volumes, I've presented this data at American College of Cardiology Heart Valve Consortium, where there were thought leaders from all over the world, not just country. And even the guy who wrote the chamber quantification guidelines said to me, but there is so much variability between how people trace the volumes. And I said, actually, our data doesn't suggest that. So in these 1,100 patients, there was an excellent correlation when about 20-25% sample was traced by 2 readers who were blinded between the volume traces. So our value 0.94 and 0.88. And what we found was that the volumes were associated with all-cause mortality and all-cause mortality censored at AVR, where we, stopped where they censored them to AVR, so don't count outcomes afterwards. That the volumes, when they were enlarged more than 45 in this blue line, and the dotted is the adjusted analysis, were associated with higher mortality than if the volumes were normal. And we performed all kinds of adjustment. We adjusted for age, we adjusted for sex, we adjusted for the comorbidity index, which includes like 19 some comorbidities. We adjusted for their symptom class, how symptomatic they were. We even adjusted for the dimensions that are in the guidelines. We adjusted for slight variation in severity. And even after, all sorts of adjustments, volume came out superior and independent predictor of mortality in patients, and even predictor of symptoms when adjusted for all the other variables. And this is that spline curve that when we plotted the volumes against mortality risk, we found that a cutoff around 45 was the optimal cutoff. So we went ahead, okay, we have done this work. How about we do some artificial intelligence research and, take the human bias out of it. So we performed a machine learning unsupervised analysis where we gave, I think we had 20 some variables, and these were the significant ones to the machine learning models, and said, okay, give us the best algorithms that would predict patient outcomes. And again, volumes in different kinds of machine learning models, including patient demographic, clinical variables, comorbidities, echocardiographic variables, including everything, volumes were independently, again, associated with the outcome of all-cause mortality with a very good AUC. This paper was published last year. Now, limitation of volumes is difficulty obtaining volumes. Sometimes, the same limitations. Patients have COPD, they have bigger size, they have scoliosis, and the variability between observers and the need to establish what is really abnormal for women in different races. So this is kind of the figure that people show when they talk about variability, that it can reach about 20–30%. So I went ahead and I said, okay, we're going to look at it systematically. Whenever there's a clinical question, we got to look at data. What does data say? We said, okay, yes, people used to say, okay, this is Mayo Clinic Rochester, 2 expert level 3 people tracing volumes. Yes, there is no variability, but can we extrapolate that to a small town, in Minnesota or rural Wisconsin, where patient may be getting their echocardiograms, and performed by non-experienced echocardiographers? So I said, okay, let's look at the data. So if you remember, when we do the volumes, we look at the 4-chamber view of the heart and 2-chamber. And most of the time, there's difficulty obtaining the 2-chamber view. And that is the one that's subjected to foreshortening. You don't see all the borders, but 4-chamber view is easily obtainable most of the time. So we said, okay, if the patients don't have any areas that are abnormal, so regional wall motion abnormality, or if they don't have significant coronary disease, can we use those 4-chamber volumes, which are very easy to obtain, as a surrogate of biplane volumes? And we found that even monoplane volumes are better than no volumes or using dimension. And again, same threshold 45 was associated with outcomes. We found a very good correlation between biplane and monoplane volumes with an R of 0.87 and 0.89. And again, they were associated with outcomes, mortality, and symptoms, and they were feasible in most cases in patients with no significant regional wall motion abnormality. So if they don't have very abnormal ventricles, some parts moving well, some not, we can still use the monoplane volumes, which are much easier to obtain. So we can also obtain LV volumes by cardiac MRI. I showed you that example, those traces. And so since our study came out in 2020, my first paper, the other groups in the Twin Cities and then Houston group have looked at the role of LV volumes using cardiac MRI. In this study, there were data from a couple centers, 178 patients, 50 events. And again, they found at a similar volume threshold of 45 ml per meter square. This threshold was associated with a composite endpoint of death, heart failure, or symptoms. And in this bigger study that included 4 centers, I believe, in Houston, 458 patients, 133 events, they again found a higher volume, slightly different threshold, 43, 45 are pretty similar, was associated with development of symptoms, drop in ejection fraction, or reaching the guideline indication for surgery or death. So sex differences in LV volumes, I'll take about 3 minutes. Are there sex differences? This study said there are sex differences, and another study that maybe the ventricle remodels slightly differently, conical in females versus spherical in males. But when you look at the finer details of the study, actually, very few patients had severe aortic regurgitation, and there were fewer females with severe AR than males. So there may be sex differences, but these two studies actually did not answer it appropriately. So that question is still unanswered, because the question is there variability beyond indexing? There are some other markers that help us assess the subclinical left ventricular dysfunction. We perform strain analysis in echocardiogram, and we can look at scar tissue in cardiac MRI that has also been shown to be associated with outcomes. So this is what the guidelines say, but what we need to capture is before there is decompensation of the left ventricle. And this is another paper which is under review, where we looked at a couple of these triggers combined, and we found that these triggers actually, there is a survival penalty by the time patients reach the current class 1 and class 2 guidelines of surgery, and operating at early triggers actually would be associated with better survival. So my take-home points are: optimal evaluation of aortic regurgitation includes assessment of etiology mechanism, quantification, LV remodeling. Assessment of LV size is best done by volumes and should be performed in all patients with more than moderate AR. There are limitations of the current guidelines, which includes valve thresholds based on old studies from 70s and 90s when operative mortality was very high. Recent data suggests stronger association of index volumes rather than dimension with outcomes, and there is role of novel markers, which includes volume, global longitudinal strain, fibrosis or scar assessment in cardiac MRI, and a cutoff ejection fraction of 60% rather than 55%. But there is need of future larger prospective studies before these can be made, these can come into the guidelines, and maybe in the next iteration of guidelines, one or all of these would be included as the cutoff for intervention. Thank you for your time.